Good afternoon. Thank you once again for the invitation. I'm going to talk to you this afternoon about pancreatic trauma. You have already a great presentation this morning about management of pancreatic and duodenal trauma. So I'll try to show something a little different from was presented this morning. Not about the final management, but other things. The points of relevance, importance, historic facts, determines outcome, classification, diagnosis, and management. So 1 to 2% of blunt trauma are pancreatic trauma, and 5 to 7% of penetrating trauma. Morbidity is high, 30 to 60%, and mortality is 9 to 34%. This paper shows in 2 years, 24 patients, 87 with blunt trauma, 12 penetrating trauma, and 70% were operated. 12.5 died, so it's difficult to handle. In our hospital, Santa Casa, in Sao Paulo, in 2 years, with more than 6,000 trauma patients, 5,500 blunt trauma, only 8 patients with pancreatic trauma. 6 was penetrating trauma, all of them was laparotomy, and damage control in 3 patients. 7 with associated trauma. Mortality high, 37.5%. And this paper shows factors associated with mortality, and they are age, RTS, shock, transfusion, damage control surgery, grade of injury, repeat laparotomy, associated duodenal and vascular injury, ICU admission, and time in ICU. So that's a difficult location because everything is around pancreas. Great vessels, duodenum, stomach, spleen, everything's around. So that's a big deal. And there's the principle, the pancreas is not your friend. No, do not count on pancreas. And there's some historic facts, very interesting. For example, President William McKinley, the 25th President of the United States of America, was the first reported case of traumatic gunshot pancreatitis. He was shot twice in the abdomen and chest and passed away 8 days after initial injury in September 14, 1901. And it's interesting, the surgery report. 1 hour and 22 minutes after injury, they perform a left paramedian incision laparotomy. No hemorrhage or extensive bleeding. The chest shot not penetrated the thorax. Traumatic opening in the anterior greater curvature of the stomach, 2 centimeters from the omentum, was sutured with silk. A larger opening was closed on the posterior wall of the stomach. No evidence of leak or other injury. Operation was concluded after 1 hour and 30 minutes. There was a high level of difficulty due to morbid obesity and no abdominal drains. Initial recovery was good, oral feeding and passed flatus and stool. However, postoperative tachycardia treated with digitalis and strychnine, and he passed away from shock. The necropsy showed suture gastric intact and extensive necrosis of the pancreas and the surrounding structures. Causa mortis was abdominal wound, gangrene, and sequelae of failing to retrieve the second bullet. And pathology not considered traumatic pancreatitis, but finding of pancreatic necrosis that represents pancreatitis secondary to undiagnosed pancreatic duct injury. So we have some determinants of outcome in pancreatic trauma. Mechanism of injury. Penetrating trauma carries worse outcome. Gunshot is worse than stab wounds. And deceleration, we can have a tear in the junction of the mobile and fixed part of the duodenum. Associated injuries, early deaths caused by hemorrhage. Vascular injuries, 75%, liver, 46%, spleen, 28%. Late deaths related to septic complications, most of them related to fistula. Time to diagnosis and treatment is very important as well. Treatment delayed more than 24 hours has an increase in mortality from 11 to 40%. and because of fistula, abscess, anastomotic breakdown, pseudocyst, and pneumonia. And pancreatic duct disruption. This is very important and occurs in 15% of patients, mostly from penetrating trauma. So this paper shows predictors of mortality and concluded that combining pancreatic duodenal injury, penetrating trauma, age more than 40 years, and uninsured patients are the predictors. The classification that we have is from WEST. Grade 1, you have minor contusion without duct injury or superficial laceration without duct injury. Grade 2, major contusion without duct injury or major laceration without duct injury or tissue loss. Grade 3, distal transection or parenchymal injury with duct injury. That's very important. Grade 4, proximal transection or parenchymal injury involving the ampulla. And grade 5, massive disruption of pancreatic head. And you advance one grade for multiple injuries to the same organ. Diagnosis. The first point to know if that patient have a pancreatic trauma is the mechanism of trauma. You have to have suspicions and you have to investigate. You have some problems, especially in clinical evaluation, because pancreas stays in a retroperitoneal position. It's very hard to have a physical examination. It's unreliable. Amylase has a sensitivity of 75%, but it's not non-specific, and may be normal, especially less than 3 hours after trauma. CT scan is gold standard in stable patient and may be normal. Sensitivity increases with time. CT scan is good to diagnose pancreatic trauma, but not so good to diagnose pancreatic duct injury. You have to know that can be normal in the first hours, 40% in the first 12 hours. This paper shows an evaluation with MDCT technology, and this improves the diagnosis of pancreatic trauma and pancreatic duct injury, what is very important. Is there another injury? I would say probably yes. Take a look at this picture. You can imagine that probably you have another injury. It's not rare to find additional injuries such as duodenum, small bowel, liver, spleen, and vessels. And ductal injury diagnosis. The key point is there a pancreatic duct injury? If there is a pancreatic duct injury, you have to act, maybe to operate this patient. If there is no pancreatic duct injury, you will observe this patient. So the question, how to diagnose pancreatic duct injury? To observe, to stand, or to operate this patient? Pancreatography, preoperative, the RCP is the gold standard. The problem is, probably, when you have these patients with pancreatic trauma, the gastroenterologist is at home. It's hard to come to the hospital at the middle of the night. You have to know that. And MRCP, the question is it safe for diagnosis of pancreatic duct injury? And intraoperative. You can also have ERCP, cholangiography with methylene blue. That's very smart because you have the cholangiography and you have the result in the operation, extravasation of methylene blue. That's interesting. Never make a section in the pancreas to get a pancreatography, and don't open the duodenum to get a pancreatography. This paper shows indicators of pancreatic ductal injury: direct visualization of an injury, complete transection of the gland, laceration of greater than 1/2 of the gland, central perforation, and severe maceration. So how to diagnose pancreatic ductal injury? ERCP is the best way, most accurate method for detecting ductal injury, invasive and associated with complications. However, MRCP is improving. It's limited but encouraging experience, non-invasive, and highly accurate in demonstrating pancreatic injuries and ductal injuries, especially if dynamic secretin enhanced MRCP. How to graduate pancreatic duct injury? The classification is class 1, normal pancreatic duct, class 2, injury to branches of pancreatic duct, class 2A, contrast within pancreatic parenchyma, 2B, contrast leaks into retroperitoneal space, and class 3, you have injury to main pancreatic duct. 3A, injury to main pancreatic duct in body or tail region, and 3B, injury to main pancreatic duct in the head. And this paper shows that classification of pancreatic ductal injuries is related to AAST classification regarding modality of treatment. So they are very similar about the treatment of these patients. ERCP or MRCP, which one is the best? Soto et al. Analyzed 7 patients with pancreatic duct injury. MRCP detected injury in all patients. Regozzino showed that secretin-enhanced MRCP improved visualization of non-dilated pancreatic duct. This paper analyzed accuracy of MRCP in identifying pancreatic duct disruption and shows that MRCP is very accurate, not like ERCP, but very similar. So maybe it should be a good idea to use that. And management of this patient. Grade 1 and 2, if you have the diagnosis preoperative, conservative treatment is the standard. Intraoperative, you have to control the hemorrhage and drainage. Grade 3 injury, you have a duct injury, so distal pancreatectomy is the best treatment, with or without splenectomy, depending if the patient is a child, stable patient, other injuries that you diagnosed, and drainage only maybe could be employed. Grade 3 injury, you can see here in yellow the pancreatic duct, and grade 3 injury here is easily to see. This paper analyzed 107 patients with distal pancreatectomy for trauma, 17% of fistula. If you perform a pancreatectomy, distal pancreatectomy, you can wait the pancreatic fistula. It's not a problem. You know that happens. Grade 4 injury, proximal injury, consider damage control if during the operation you need to drain and maybe stent. Grade 5 injury, severe pancreatic injury, damage control. You have to consider that and postpone reconstruction. This algorithm is very interesting. It was demonstrated this morning. And pancreatic injury, proximal, closed suction drainage. If you have a distal injury with ductal injury, distal pancreatectomy and closed suction drainage. If the ductal injury is indeterminate, if low probability, closed suction drainage. If high probability, distal pancreatectomy. Very simple and very smart to follow this algorithm. Intraoperative assessment, you have signs of alert. Central retroperitoneal hematoma and blood in the lesser sac. Damage control surgery in high-grade pancreatic duodenal injuries, you have to consider that. This paper, also from Memphis, analyzed 245 patients with pancreatic injuries in 13 years. You have 69% of penetrating trauma and 60% of death. When you analyze 210 patients, 4 late deaths because of associated injuries, 87 proximal injuries and 7 fistulas, 123 distal injuries, 71 associated with intestinal injuries. The fistula was present in 9% of patients. So, is non-operative treatment possible in patients with main pancreatic duct injury? This paper analyzes pancreatic injury in children and shows 34 patients, 31 non-operative and 3 in the surgical group. The 3 patients in the surgical group had instability, grade 3 injury, peritonitis, grade 2 injury, and suspect of bleeding. No long-term morbidity happens, except the pseudocysts, and no mortality. So, non-operative treatment is safe, is that conclusion. However, 50% of pseudocysts, you have to know that. Another paper analyzing traumatic pancreatic duct injury in children, minimally invasive approach to management. They analyzed 15 patients, 9 patients with ERCP and stent, no resection. And they suggest an algorithm that's very interesting because suspected pancreatic injury, you have a CT scan to define parenchymal injury, duct injury unlikely, clinical review, duct injury likely, MRCP to define duct injury, and then diagnostic ERCP and therapeutic duct stenting. Failure to stent or development of fluid collection of pseudocyst, percutaneous endoscopic aspiration and drainage. There is no resection in this algorithm. That's very interesting. This paper analyzed surgical versus non-surgical management of traumatic major pancreatic duct transection. 51 patients with major pancreatic duct transection, 39 with surgical management and 12 non-surgical management. Surgical treatment had less use of TPN and less length of stay, but complications and fistula were the same. In conclusion, surgical and non-surgical management of main pancreatic duct injury from blunt trauma can be performed successfully. This paper compares operative and non-operative management for blunt pancreatic transection in children in a multi-institutional outcomes, and they conclude that blunt pancreatic transection with main duct involvement is best managed with resection because pseudocyst is almost 50% of patients, the same result of the previous paper. And additional investigation of MRCP or ERCP if there is doubt about the status of pancreatic duct. That's a paper about the role of endoscopic ERCP in pancreatic trauma, analyzing 48 patients, and concluded that endoscopic interventions were more successful in managing pancreatic fistula and pseudocyst than in managing patients with main pancreatic duct strictures. So, injury to the head of the pancreas, drain, maybe stent and down Whipple. Damage control surgery would be a good idea. This paper analyzed the Whipple for trauma in a single institutional experience, 276 patients, trauma patients in the pancreatic duodenal complex. 15 patients underwent Whipple, but 12 of them, 80%, underwent damage control surgery and then Whipple surgery. Mortality, 2 patients, 13.3%. Trauma Whipple, do or don't after severe pancreatic duodenal injuries. No difference between Whipple and non-Whipple, so you don't need a Whipple. It's better than a Whipple. Laparoscopic surgery. Is there a role for laparoscopic surgery? This paper compares laparoscopic versus open distal pancreatectomy in the management of traumatic pancreatic disruption. Similar results. That's an initial experience, but similar results. The surgical principles in pancreatic trauma are hemorrhage control, wide external drainage, judicious debridement of resection, limited use of pancreatoenteric anastomosis. It's very important. That's classic, but I have to show you again. Pancreatic trauma is like a crawfish. Suck the head and eat the tail. Everyone in a lecture about pancreatic trauma shows a picture like that. And I have to show it again because it's important, simple and important. And we have this very interesting algorithm from the Western Trauma Association. with Dr. Moore, Dr. Coimbra, Dr. Feliciano, that developed an algorithm about pancreatic trauma. So first of all, if you have abdominal trauma, you have a CT scan on A, and normal pancreas or peripancreatic edema and non-operative management. If you have pancreatic laceration or moderated peripancreatic fluid, MRCP. Main duct injury? No. Okay, non-operative management. If after the CT scan you have pancreatic transection or extensive peripancreatic fluid, you go to laparotomy. At laparotomy, you have a contusion here at F. You have closed suction drainage. If you have grade 2 injury, laceration with low risk of ductal injury, the same, closed suction drainage. If you have a laceration with high risk of ductal injury, grade 3 or 4, depending if it's right of the SMV, closed suction drainage. If it's left side of SMV, distal pancreatectomy. During laparotomy, if you have a massive disruption of pancreatic head, grade 5, damage control with drainage. And in the second time, drainage with pyloric exclusion or pancreatic duodenectomy. So it looks complex, but it's very simple, very smart, and this algorithm shows that there is a role for the MRCP, that's very important, and the distal pancreatectomy is safer for patients with grade 3 injury. So in conclusion, you have to have a high suspicion of pancreatic trauma. Associated injury is common. And how to diagnose pancreatic duct injury? MRCP is very interesting, and ERCP is still gold standard. How to treat a pancreatic duct injury? Body and tail of the pancreas, distal pancreatectomy. Clinical treatment might be possible, associated with minimally invasive methods. And head of the pancreas, avoid Whipple in the first operation. Damage control could be a good idea. Stent could help, and drain is really very important. Once again, thank you very much for the invitation, and congratulations for this amazing meeting.